Hello, everyone. I am Dr. Mark Prats. At the time of the recording of this lecture, I am currently the medical director for the IDMT course at GBSA Fort Sam Houston. So in this lecture, I'm going to introduce the concept of differential diagnosis building. Now, this is directed to our Air Force IDMTs, who are highly trained medical assets for the United States Air Force, who provide high quality care to our service members all around the world. Now, our IDMTs are provided a wide ranging collection of medical resources and tools to help guide them through the medical management of literally hundreds of acute medical issues. But to utilize these resources effectively, our IDMTs need to know what they are looking at and what they are looking for. And that's where differential diagnosis building comes into play. So in this lecture, what I want to do is have us learn the art of differential diagnosis building to take our medical care to the next level. So let's get started. So this is our obligatory disclosure slide. The opinions provided in this lecture are mine alone and do not necessarily reflect those of the U.S. Air Force or the U.S. government. I have no disclosures at this time. This lecture doesn't hawk any products, and so no worries about me benefiting unnecessarily. So we're going to start off by discussing why medical providers build differential diagnosis lists. We're then going to look at when in the medical encounter we start and when we refine these lists. And next, we're going to take a look at a couple of methods and strategies for how we build these broad differential diagnoses. And then we'll close things up by taking what we've learned and applying it to a practice case. So why do we do this? Well, as medical providers, what really separates you from the rest of the medical team is the ability to build these differential diagnoses. When a provider builds a differential, they're critically thinking about the patient in front of them, considering all the unique factors that feed into their case. And then that provider is using that information to guide them through that encounter. Now, whether they realize it or not, from the moment that they meet that patient, they're really building their differential, and they're using that to guide the questioning that they are conducting with that patient. Once they've completed the HPI and ROS section of their encounter, they will then refine their differential diagnosis list and use that list that they have remaining to guide their physical exam. You're not necessarily going to do a shoulder exam on every patient that comes in, but somebody that comes in with shoulder or neck pain, there are a number of diagnoses that you need to tease out, and doing a physical exam of the shoulder will help you do that. Once you've completed your physical exam, you then can continue to refine your differential diagnosis list and use that final list to come up with the most likely diagnosis, determine how urgent this patient might need an additional workup, and what that additional workup might entail. So when do we build this? We kind of covered this a little bit already, but if the differential diagnosis list is guiding us through the entire encounter, then we need to start building it from the first moment that we see the patient. So that chief complaint and that first look that you have at the patient, you should immediately be starting to think of different things that might be causing this patient's symptoms. You then are continuously refining it. Every question you ask and every response that the patient gives you, you should be checking off or adding to your differential diagnosis list based on that. And that's going to help guide you throughout the encounter. I often find that it's helpful to write in my assessment and plan some of my thoughts that I had throughout the encounter with regards to my differential diagnosis. This can be helpful for future me to understand what I was thinking. It can also be helpful to future providers that are seeing this patient to get a better idea of what the patient looked like in front of you at that moment. You're always trying to paint that picture of what you're seeing in your notes so the next person that comes along and reads it knows what you are actually dealing with. So how do we build these differential diagnoses? This is the fun part. And so there's a couple of different ways that we'll discuss, and the first one's going to be this systems-based method of building differentials. This way is a little bit more complex. It can be a little bit convoluted, but it definitely results in very broad, wide-ranging differential diagnoses. Now, the way that we do this is we look at the chief complaint or the list of complaints that the patient has come in with, and we build a list of potential diagnoses from multiple different organ systems that could be potential reasons why the patient has these symptoms. So I'll give the example of a headache here. You could think kind of classically that all headaches are likely to come from a neurologic source. So is this like a primary headache, like a tension headache or a migraine? Could this be meningitis or encephalitis? Might think about your ENT system. Could their headache be related to sinusitis? Could it be a tension headache or neck strain related to just muscle myofascial tightness that the patient's having? Or is this some sort of vascular issue like a bleed or an inflammatory condition of some of the vasculature up on their head and neck region? And lastly, could it be an infectious cause? So we talked about meningitis, encephalitis, but also something like Lyme disease or some sort of abscess that might have formed in and around the brain. There are a couple mnemonics that we have to help make sure that we haven't missed any of the organ systems as we're building our differential diagnosis. So two of the more common ones are going to be vitamin C, D, E, where each letter in the mnemonic stands for a different system, V being vascular, I for infectious and inflammatory, T for trauma or toxin, A for autoimmune or allergic, M for metabolic, that second I for iatrogenic or idiopathic, which basically means did we cause this, being iatrogenic, or do we not know what it is, being idiopathic, N for neoplastic or cancer, C for congenital, D for degenerative, and E for endocrine. If you don't like that mnemonic, there's another mnemonic that covers basically the same items, Vindicate. Many of the letters are the same. A couple that are just slightly different is really just that second I, iatrogenic intoxication, being just slightly different, and then the E, endocrine and metabolic, just combining a couple of letters from the vitamin D, C, E. Now, when you're building your differential diagnoses, I challenge you to, at a minimum, try to find diagnoses from at least 4 different organ systems. And you should hopefully be able to find diagnoses from more than that, especially early on in the case. But by doing that, what you're going to do is broaden out your thought process so that you're not missing some of the more subtle findings in your exam and putting the patient at risk for harm long term. Now, the other method that we'll talk about here for building differential diagnosis lists is what I call the anatomy-based method. And so this one's a little bit simpler. And what you're basically doing here is you're taking the patient's presenting symptom and the location of that symptom and then thinking about all the structures that are there. Now, this works probably best for patients that are presenting with pain somewhere in their body. Maybe not so much with other types of symptoms like vertigo, nausea, that have a little bit more of a diffuse or systemic association with them. So if we think about like the patient that has right upper quadrant pain, we might think about all the different structures that live there, right? So in your right upper quadrant area, you have your liver, and so you might think about hepatitis. You have your gallbladder, so you may think of cholecystitis, cholangitis, cholelithiasis. You have your pancreas, so pancreatitis could be an option. Your stomach lives there, so gastritis and peptic ulcer disease. Your lungs are even kind of in that area, and so you got to be thinking about pneumonia. All your bowels kind of run all throughout your abdominal cavity, so gastroenteritis and colitis are definitely things to think about. Like I mentioned earlier on, you could have somebody whose anatomy is just slightly different than what the textbooks say. And they could have right upper quadrant pain because their inflamed appendix is tickling their perineum, or peritoneal cavity higher up in their abdomen. They could have urinary stones because their kidneys and their ureter are up in that area. Pyelonephritis because their kidneys are there. And then thinking about their aorta, which is also in that area. Could this be like an aortic dissection that's causing their symptoms? So now that we have some background, let's go ahead and practice. So in this case, we have a 30-year-old patient. We're not going to say whether they're male or female because that helps to broaden our differentials as revealed in these a little bit more. That's going to present with some right lower quadrant pain. So immediately when you see this on the patient's chart, you should start to think about different things that could be causing the patient's symptoms. So we'll start off by using the systems-based model, and let's go ahead and just use the Vindicate mnemonic. So for V, vascular, we might think about mesenteric ischemia or aortic aneurysm. So mesenteric ischemia being loss of blood flow to portions of the bowel due to clots or a myriad of other reasons. I for infectious and inflammatory. So quite a few things here. So appendicitis is probably the first thing that you guys thought about. You also got to think about gastroenteritis, something that maybe is a little bit more common that might trick us from time to time. Like I said, you have bowels all over your abdomen, so colitis and diverticulitis could be a potential cause. Pelvic inflammatory disease, tubo-ovarian abscesses in females, and UTIs all might present with that right lower quadrant pain. So N for neoplastic, could this be a cancer somewhere in the colon or throughout the GI tract? D for degenerative, I kind of put hernia in here for degenerative, whether that's an inguinal hernia or a femoral hernia. It might present with some fullness or even more severe pain if that hernia has become incarcerated or strangulated. I for iatrogenic, did we do a surgery previously? And now this patient has a hernia that's going through one of our old incisions. C for congenital, there's a few congenital conditions that might present with some lower abdominal pain, Meckel's diverticulum being one of those. A for autoimmune, we kind of discussed a little bit of the inflammatory stuff, but we didn't mention maybe like a Crohn's disease or inflammatory bowel disease, but I didn't initially put anything there just to kind of show you that you don't always have to have something for every diagnosis. T for trauma, so again, you could put your incisional hernia here, the trauma being the fact that they went through the surgery, or T for the trauma being the testicular torsion that might be presenting with some right lower quadrant pain radiating from the scrotum. E, which stands for endocrine, but I also include a lot of reproductive things here. So urinary stones, hypercalcemia, hyperparathyroidism are a couple things that often present with abdominal pain. For females, ovarian torsion, ectopic pregnancy, and ovarian cysts are things that commonly will present with right lower quadrant pain. So as you can see here, we have a really wide-ranging list of potential diagnoses for this patient that presented with right lower quadrant pain. And so what we can do is take the information that we've gathered from our history and physical and start to determine which one of these things are more and less likely, and that will help guide us into determining what additional steps we need to take to further evaluate this patient's condition. So next, we'll take a look at that same patient with the right lower quadrant pain, but this time we'll build our differential diagnosis using the anatomy-based method. So some of the structures in the area include the appendix, the colon, the small intestine, the ureter, bladder, the ovaries and fallopian tubes, uterus, spermatocord and testicles in males, and the aorta. So now for each one of these structures, we then will think about potential diagnoses, different pathology that can happen with these structures that might be causing the patient's symptoms. So for appendix, obvious one, appendicitis. For the colon, similar things that we've mentioned before, the colitis, ulcerative colitis, Crohn's disease, gastroenteritis, and cancer. For the small intestine, some similar things. We added hernia and celiac disease here. For the ureter, we talk about urinary stones or like a ascending pyelo or a UTI that's developing into a pyelonephritis. It could just be a simple cystitis, also known as a UTI. For the the ovaries and fallopian tubes, it could be an ovarian torsion, ovarian cysts, especially if they rupture, can be extremely painful. You always have to be on the lookout for ectopic pregnancies in females of childbearing age, and then a tube ovarian abscess, which can be a pretty gnarly infection in the pelvic area. For the uterus, you can have pelvic inflammatory disease, endometriosis, adenomyosis, and dysmenorrhea. For males, testicular torsion, epididymitis, and orchitis are all things that may present with that right lower quadrant pain radiating from the scrotal area. And lastly, for the aorta, we might think about an aortic aneurysm or an aortic dissection. Now, what's interesting about this is that even though we used an anatomy-based method to build this differential, you can see that there are several different organ systems that we used. And so we used the GI system, looking at the appendix, the colon, the small intestine. We looked at the GU system, looking at the ureter and the bladder, the GYN system, as well as the male GU system. We have diagnoses in the vascular system. And if you think about hernias or abdominal wall pain being musculoskeletal origin, you could add MSK as another organ system that we considered. So you can still build a very broad differential by using this anatomy-based method of differential building. The only caveat that I say is that it works best in patients that are presenting with pain, not quite as effective in individuals that are presenting with more systemic type symptoms. In those patients, you're probably going to do better to use that systems-based method with those mnemonics that we talked about. All right, so to recap, we introduced the concept of differential diagnosis building. We discussed why we build these differentials and how we use them to guide us through the encounter and make decisions about what to ask, what exams to perform, and what to do next. We talked about that we need to continuously be building and refining these differentials based on the findings that we have with our interaction with our patient to make sure that we're being guided in the right direction. And finally, we saw a couple examples of how we build these differential diagnoses with their pluses and minuses, and we got to practice them in an example case at the very end. So that concludes our talk on differential diagnoses. I hope you found this talk helpful. I look forward to discussing more high-yield medical topics with you as we go beyond the aid bag in the future.